It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Okay, thanks for joining us. Really happy to be back. It's June, almost June of 2026, and we have a lot of great things coming up. We have this summer, ASPN. I'm going to help out with the lab. We have an ultrasound and regenerative medicine course with Christopher Robinson, Ali Valley Moed, and a whole bunch of all-star pain docs who are set to teach this cadaver/model course in Miami at ASPN. The ISPN is going to follow in Europe. I believe it's Amsterdam in October. Hopefully I'll make it to that. Latin American Pain Society is coming up in a month in June. That's going to be amazing, as well as Pain Week in September in Las Vegas, where I'm going to be lecturing on AI and ultrasound and pain medicine. So board prep time is upon us, and before we get into that, I just want to remind you all, I'm doing ultrasound IV courses as well as ultrasound regenerative medicine target, as well as PNS target regional anesthesia courses in New York City as well as elsewhere, and I hope you guys could make your way to those courses because they're a lot of fun and it will most definitely alter your practice. We go over the billing, we go over all the nuances of performing these procedures and getting paid for them, especially with an angle focused on regenerative medicine, which is of course here to stay and a real big deal because it actually works for many people. And it's something that when the insurance company is not involved, you could be a true doctor. You could take care of their facet with their shoulder on the same day or their epidural with their facet on the same day, etc. So there's really a lot you can do with regenerative medicine that you can't do with traditional insurance models. Anyway, as far as the board prep goes, I've created a program for tutoring. Actually, it was at the request of a student who failed the boards, and I created a group of private sessions if anyone is in need of extra help. And this is something that's a 1-hour session that is keyword focused, taking it straight from the ABA, ABPM, ABIPP syllabus or outline for the boards, and we go over flashcards, keywords, practice questions, etc. So if you're interested, just reach out to me privately. The email is info@nrappain.org. And if you're looking to sign up for any of the courses, just go to nrappain.org for the virtual pain fellowship or the PainExam board prep question bank. Okay, so today we're going to talk about really big topics on the boards: occipital neuralgia, headache caused by the occipital nerve or the nerves that lead to that, like a cervicogenic headache can lead to this. Any pain in the occipital nerve distribution, which is the posterior head, and the greater occipital nerve arises primarily from the dorsal ramus of C2. It's you could also have referral to the lesser occipital nerve, which is C2-3, and the third occipital nerve, which is mainly C3 medial branch. The nerves provide sensation to the posterior scalp occipital region. Patients will report sharp shooting pain, electric shock-like sensations, posterior scalp tenderness, pain radiating toward the vertex, dysesthesia or allodynia over the nerve distribution. Symptoms are usually unilateral, but they can be bilateral. And the boards will test this either as a cervicogenic headache. In that case, you may want to consider radiofrequency ablation of the cervical medial branch nerves to C2 and C3. They'll talk about migraines, cluster headaches, tension headaches, Chiari malformation. Typically, patients with occipital neuralgia will have tenderness over the occipital nerve. There will be a Tinel sign, and you can reproduce the symptoms with palpation. Conservative treatment is physical therapy, neuropathic medications, muscle relaxants. I'm going to add, it's not listed here, even NSAIDs may help. Interventions: greater occipital nerve block, pulsed radiofrequency, cryoneurolysis, peripheral nerve stimulation. Broad pearls, diagnostic nerve blocks can be both diagnostic and therapeutic. If you've ever done a medial branch with lidocaine, occasionally the patient gets cured. I mean, that does happen, or at least gets long-term relief. So remember that the nerve is mainly from C2. If they give you C3 or C2-3 as an option, you may want to put that mainly for the third occipital nerve, which does respond to RFA. And just of note, I had a video on ViewMedi with me performing an occipital nerve block under ultrasound, and some person, I assume it's a doctor because it's a medical platform, not really meant for patients, basically left a comment saying that nerve blocks targeting peripheral nerves do nothing to address the central problem of a headache, and all they do is benefit the physician's bottom line by doing unnecessary expensive procedures. So basically, this guy just called out myself as well as other interventional pain physicians for performing nerve blocks for headaches as being greedy and just doing it for our own benefit. First thing I did was ask him if he's a physician and to see if he's a pain physician or where he's coming from. I'm almost positive he's not a pain physician because no pain physician would ever say such a thing because it's flat out wrong. Like everything, patient selection, right? If not every patient responds to a nerve block. However, if you're an interventional pain doctor, you've seen patients respond to occipital nerve blocks, and you know that sometimes treating peripherally a central problem can make a big difference. And then the question is it really a central problem, occipital neuralgia? Well, if it's a muscle impinging the occipital nerve peripherally, it's not a central problem. Or if it's an arthritis of the C2-3 facet joint or muscle tension causing this, well, it's not really a central problem. But that being said, patients who have central problems such as disc herniations do tend to respond to peripheral nerve blocks such as suprascapular blocks or brachial plexus blocks or extraforaminal selective nerve root blocks. So this physician, who I'm not mentioning his name, or this person, in my opinion, is quite ignorant and should watch what he says. I also mentioned that the $100 or whatever it is that Medicare pays for an occipital nerve block is a lot less money than 12 months of follow-up for migraine headache management or the migraine drug itself. And theoretically, this occipital nerve block can cure the patient. So I don't think this guy knows what he's talking about, and I basically replied that way on my on the ViewMedi platform, and hopefully he's educated now. He's been silent since, so either he didn't see it or he now understands that he was probably pretty stupid for making that comment. Anyway, kyphoplasty versus vertebroplasty. Well, kyphoplasty uses a balloon. There's actually a study I found comparing them, trying to figure out which one is better. It was a meta-analysis. I'll put the reference in the show notes. But before we get into the conclusion, osteoporosis and osteoporotic compression fractures, it's something that's very common in the elderly especially. These patients do need to go to pain management for pain relief and fracture stabilization. This was a meta-analysis comparing the two techniques. They looked at 8 studies, and the results they found were that kyphoplasty was shown to be superior to vertebroplasty in terms of reducing cement leakage and increasing postoperative vertebral body height. The comparison of the rest of the outcomes that they looked at, such as VAS as Westry, kyphotic wedge angle, and vertebral, those were statistically insignificant. So they concluded that although kyphoplasty can significantly increase postoperative vertebral height and decrease the risk of cement leakage, the fact that it is more costly and has a longer operative time raises the question about the cost effectiveness of the procedure. That's just a little caveat. Going back to the boards, well, compression fractures come from either osteoporosis, multiple myeloma, metastatic disease, chronic corticosteroid use, and trauma related in these patients who have these risk factors. Sometimes it occurs without trauma. The thoracolumbar junction is the most frequently affected region. Patients typically present with acute axial low back pain. Pain is worse by standing, limited mobility, point tenderness over the fracture. Neurologic deficits are uncommon unless retropulsion occurs. MRI is useful for determining fracture acuity. Acute fractures often demonstrate bone marrow edema on stir. The procedure is injecting PMMA cement into the vertebral body for stabilization and pain reduction. Kyphoplasty, there's a balloon tamponade that creates a cavity before the cement injection. It has the advantage of partial restoration of vertebral height and reducing cement extravasation, complications, cement leakage, pulmonary embolism, adjacent level fractures, and infection. On the board, they'll ask how do you identify acute fractures. It's MRI stir. Cement leakage is the most common complication, and kyphoplasty may restore vertebral height better than vertebroplasty. Indications for kyphoplasty include fractures due to osteoporosis, multiple myeloma, metastases, vertebral angioma, and intractable pain with no neurological symptoms. The main contraindications are coagulopathy, unstable fractures, or complete vertebral collapse, vertebra plana. Kyphoplasty is proven to be a safe and effective method for treating intractable pain due to vertebral collapse, allows for shorter hospital stays and immediate improvement of the patient's quality of life. Of note, relative contraindications include vertebral collapse of more than 75% of the regional height, tumors extending into the spinal canal, moderate coagulopathies as mentioned above. Active fractures in patients without osteoporosis, multiple compression fractures, and asymptomatic compression fractures can pose clinical dilemmas. And deficiency in posterior vertebral cortex raises concerns about cement leakage. And the decision to treat a non-fractured vertebral body, especially when adjacent fractures are present, remains debated among experts. Pedicle fractures also raise concern about proper cement containment and can represent relative contraindication if stability is compromised. So that's probably all you need for kyphovertebroplasty for the pain boards. Of course, you can't predict what they'll ask you, but I hope it helps you. This is a very useful procedure. You need to just choose your patients wisely. Upon closing this out, this article, which you'll have the references here, they do go over the preparation, and to be honest, they're a little more lenient than I am when it comes to this. I'm a little more stricter. I don't do much kyphoplasty or vertebroplasty. However, their goal, INR less than 1.5 to 1.8. I'd say less than 1.5. I don't think anything. I'm going to treat this like an epidural. I want that INR 1.4 below. They transfuse any platelets less than 50,000. Okay. But this is a large trocar to get into the bone. Aspirin hold 3 to 5 days pre-procedure. Plavix or clopidogrel 5 days. I would do 7 days. Anyway, this low molecular weight heparin hold 1 dose pre-procedure if prophylactic dose is used. Hold 2 doses if therapeutic dose is used. Antibiotics pre-op, of course. You could give anesthesia. Anyway. There's instructions. There's a cookbook on how to do this procedure in one of these references, so I'll post it for you guys. Hope this was useful. Hope you guys ace the boards, and I see you guys at the upcoming conferences or my courses. Just check out the nrappain.org website for more details, and I'll see you later.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.